some of this should be reviewed for you guys. But when you look at the rib cage, of course, up top, you have a cervical region, the ribs and the articulation of the sternum is close to horizontal. Not quite, but it's a little bit angled, but it's close to horizontal. And then as you work your way inferiorly, you'll start to notice that there's a pretty big angle. If you look back through the cage here, you can see the angle of the ribs as they work their way around. It's pretty oblique before they meet up with this costal cartilage, the rib cartilage that attaches to the sternum. Just sort of keep that in mind as you go through just the general setup for the thorax. You'll see that the first 7 ribs are considered to be true ribs. True ribs. I know you guys have probably heard of that before, true ribs versus false ribs. Why are these guys considered to be true ribs? They attach to the sternum. The last thing you said is the key, directly. They directly attach to the sternum by way of this costal cartilage. So you can count the first 7 all the way down to here. And you will notice that if you follow the plane of the rib all the way directly back to the sternum, you'll see that solid connection. So those are considered true. Now, the next 3 are considered false. The reason those are considered false is because they still have an attachment to the sternum, but it's not directly, it's indirectly by way of other costal cartilages. You can see that here. So this is 8, 9, and 10. They all have a costal cartilage, the same as you have up above in 1 through 7, but all 3 of these cartilages usually funnel in towards one piece of cartilage that then buries itself into the 7th costal cartilage here, and then it's carried all the way back across to the sternum. So that's how you can differentiate a true versus a false. The first 7 directly attached to the sternum, 8, 9, and 10 have an indirect articulation. And then we have 11 and 12. 11 and 12 are called free floaters. It makes sense. They have no costal cartilage, right? They're just floating out in space. So what's the purpose? I mean, if you look at the thorax and you see the ribs, you see the cartilage, you think of the vital structures that are deep to it, like the lungs, the heart, right? Those things are kind of a big deal. So you want to keep those protected as much as possible. So what's the purpose of having 2 little floaters back here that don't even reach around to the lateral side of the body? They just stay posterior and they have no connection to the anterior side. What's the point? Protect the kidney. Protect the kidney. That's exactly right. The kidney is a posterior structure that we'll talk a little bit more about once we get the belly. But the kidneys are a posterior structure, and these are big time protection for the kidneys. Just sort of file that away until we get there later. Now, when we look at the sternum, let's focus on the sternum just for a second. You'll see that the sternum is collectively all of the structure. It is subdivided into 3 different portions. You have the manubrium. You guys heard that term before, manubrium? Manu, any Spurs fans out there? Manu Ginobili? I see you back there, banging. Manu, in this case, is in reference to the hand, right? So if you hear somebody say Manu, Manu's hand, combat. So this is the handle of the sternum. This is the body. Then all the way down to the distal portion is the xiphoid process. Now, who here has their CPR certification? Okay, what's sort of important about the xiphoid process in reference to CPR?
Looks like you
Don't break it. Yeah, leave it alone. So that's why you feel for the xiphoid, you go about 2 finger widths superior to it before you can start your compressions. That way you're not pushing on the xiphoid process. But you can see between the sternum and the xiphoid, you do have an articulation, right? So it's already sort of a built-in breaking point, if you will. So you want to make sure that you're a little bit above that before you can start your compressions. But again, you have the manubrium, the body, and the xiphoid collectively. That is your sternum. Now, if you'll notice here, the superior part of the manubrium, there's a little indentation. That's called the jugular notch, or the suprasternal notch. Either one's fine. That's why you gotta love anatomy, like we said. Things have 4 different names sometimes. As long as you remember one, you're good. But this is called the jugular or the suprasternal notch. Suprasternal, by definition, makes a little bit more sense. So maybe if you guys want to focus on that one, that's fine. But that's an important landmark, of course, but not quite as important as the one that you see here, the connection between the manubrium and the xiphoid. This is called the sternal angle. The sternal angle. Some guy named Lewis found it, so he named it after himself. Sternal angle of Louis. intercept the lower border of the T4 vertebrae. So let me say that again, because you might see that on the exam. Okay? The sternal angle, if you drew an imaginary line directly posterior, it would intersect the lower border of the 4th thoracic vertebrae. That's very important to us. There's a lot of things that are happening inside the body along that plane, right? That's the sternal angle. This also shows you the indentations on both the lateral sides for the costal cartilage for the articulation. So like we said before, there's 7 true ribs, so there should be 7 articulating spaces on both lateral sides. I think you can see those pretty well. It also gives you a good view of the costal cartilage with the connection between the rib and the costal cartilage. Now, if any of you guys have ever been hit in the chest before and it feels like you've cracked the rib, the odds are you probably sort of separated the cartilage from the rib a little bit if it's more on the anterior side. So if you have more lateral pain with your ribs, you're thinking more of a cracked rib, a fractured rib, something like that. But if you get hit from the anterior and you have a little bit of anterior pain just off the midline, odds are you just sort of irritate that costal cartilage. And just like any other cartilage in the body, it has poor blood supply. So it takes a long time to heal. So this is sort of a long process to do. And the last thing, you can see it a little bit here, we'll talk about it again a little bit later. Just underneath the rib, there's a little bit of an indentation. This is called the costal groove. Costal groove. This is just inferior along each rib, and there's sort of a dugout hollow space that runs all the way towards the anterior side of the body. It's called the costal groove. We'll talk about the structures that pass through there in just a second. Now, last week we talked about the typical thoracic vertebrae and how many articulating facets there are on that. Right, there's 10. We talked about the 4 that's in reference to the vertebrae above and the vertebrae below. But our focus today, you can see the highlighted area here that have it blown up. Our focus today is to look a little bit more at the rib and their articulation. Because again, remember what we said, when you're talking about the thoracic region, this is a big area for protection of those deeper structures, the lungs, the heart, and things like that. So you need this area to be as movable as possible for respiration, but you also need it to be as stable and strong as possible for protection. So when you look at this highlighted area here, you'll see it's blown up. This is the head of the rib. The head of the rib articulates with 2 different vertebrae. That's why you see one small facet here and one small facet here on the vertebral bodies. So the head of the rib sort of butts against both of those, articulated with both. Now the key here is that if you had one rib, the head of the rib articulating with just one vertebrae, if you had damage to that vertebrae or if you had damage to that rib, that whole side would be compromised because you don't really have a backup plan for stability and strength, right? But the fact that it articulates with 2 different vertebrae gives you a backup plan. It gives you a little bit of strength if the articulation above is damaged or the articulation below that lower facet is damaged. So the head of the rib articulates with the facets here along the vertebral body. And you'll also see this is sort of superimposed, so this is trying to show you what's deep to the structure. But you see the transverse process, right? And you know that there is an articulating facet on the transverse process of the thoracic vertebrae. And that is for the tubercle of the rib. That's the articulation here. That's the articulation here. I think I briefly said it before about TNT, transverse process, rib tubercle, right? That's the TNT articulation. So if you look at the facet here, it's showing you transverse process facet and tubercle facet as they articulate with each other. So this is a real unique setup. As you work your way inferiorly down towards the lumbar region, you'll start to see the head of the rib does start to shift away from both vertebral bodies a little bit, so it's no longer sort of equally shared along each vertebral body. But I think you get the idea of the big picture setup. So far, so good? Now again, we sort of take this as we go through like a dissection. So once you take the skin, look at the skin and superficial fascia, this is what you would see the breast tissue, basically this is a modified sweat gland. So when you see these arrows, it's talking about the lymphatic drainage, either heading out of the breast or back into the breast. So of course you see sort of a rounded aspect to the breast here, but there's also an axillary tail that extends back into the armpit. So one thing that's worth mentioning here is that anytime you hear axilla, it's in reference to the armpit. So the axillary tail is this extension of the breast tissue back into the axilla, the armpit. This is relevant to us when we think about the metastasis of breast cancer. Okay? There's a group of lymphatics that sit in the axilla, which is about 4 different subsets within it, but we just call it the axillary lymph nodes for now. Okay? You have the lymphatic drainage from the breast. It is a direct drainage back into these axillary lymph nodes. Have you guys ever heard of a sentinel lymph node before? Does that sound familiar? Sentinel nodes? There's certain nodes that are a little bit larger, a little bit more prominent throughout the body, and if you're going to sample for some type of metastasis, you look for those sentinel nodes. So those are nodes that have like multiple drainages coming in, sort of like a hub, like an airport hub or the hub of a bicycle tire, all those spokes coming into it. So you know if there's metastasis in that hub, that there's a very good probability that there's metastasis somewhere else from there as well. Okay, because it's so important to have so many drainages into and out of it. But if there's not any in that hub, then you can sort of localize and sort of compartmentalize it a little bit better. So in this case, the first place that you would look for the spread of breast cancer would be these axillary lymph nodes, and it's because of that axillary tail. And if you see it somewhere, if you hear it in the reading, it's sometimes called the axillary tail of Spence. It's the same thing. Okay. A lot of these older anatomy terms are named. They named them because of the person that found them. So a lot of times we try to avoid those two small names as much as we can, but they're still very prominent in reading if you search online. So we mention them, but we try to leave out people's names as much as possible. So that's the axillary tail. Now keep in mind that the cadavers that we have in lab, older females, okay, so over time, the ligaments, there's ligaments that support the breast tissue to help give it the shape that it is. And over time, those ligaments will start to sag. Okay, these are suspensory ligaments. And just like any other ligament, over time, they become more lax. Okay, so these suspensory ligaments, also called the ligaments of Cooper, again, is another too small name. But these suspensory ligaments, or the ligaments of Cooper, will have the breast tissue sort of filling in these pockets. So if you can hollow out the tissue, it would look just like a network. It's not like a grid, it's just a network of little cups that are sitting there. And the breast tissue fills those cups. Okay? Over time, those cups become stretched. So when they become stretched, especially on the older females that we have in the lab, you'll no longer be able to really differentiate between these structures here, the lactiferous ducts and the lactiferous sinuses. Now, the purpose of the lactiferous ducts and sinuses is for the milk flow. Okay? So since these are older females, of course, this system hasn't been used in quite a while, so it will atrophy. But it's just a big picture. You'll keep this in mind. The lactiferous ducts are sort of situated all throughout the breast tissue, whereas the sinuses are sort of the bottlenecking of all of these ducts just inside the nipple. And that's possible. We might be able to see a little bit of these sinuses upstairs, but the ducts probably not. Once you take away the breast tissue, now we're down to the muscles. This muscle that you see here is the pec major, pectoralis major. The name tells you major, it's big, right? But it's big in reference to the other pectoralis muscle, which is the minor, which is just deep to this. We'll see in a second. This is the pectoralis major. Now it has two heads to it. That's why you see here clavicular and sternocostal. So you can see here's the clavicular part of it. There's actually a little bit of break in the muscle. Sometimes that shows up, sometimes it doesn't. Not a big deal. But if you just look for the fibers that are associated with the clavicle versus the fibers that are associated with the sternum, all the way down to the costal cartilage, you can tell clavicular versus sternocostal. But they all share a common insertion here on the anterior side of the humerus. Okay, so that's important. The fact that this muscle is so broad shows you that it has fibers that are pulling up towards the head, but it also has fibers on the lower part of it that's pulling down towards the body, down towards the belly. muscle inserts on the anterior side of the arm. Okay, the anterior side. So these muscles contract. It will help to immediately rotate the upper limb. There's also another muscle that we talked about last week that inserts just beside the insertion for the pec major, and that's latissimus dorsi. Remember how we said it was very wide along the back, but it inserts, it sort of bottlenecks, and it inserts on the anterior side of the humerus. So these guys insert side by side.
Did you say abduction or adduction?
Add ADD. Adduction. Adds to the midline of the body. Pulls the upper limb towards the midline. Now, just like any other muscle, there's lots of secondary actions. Okay, so we try to focus just on primary actions. Sometimes a muscle has 2 or 3 primary actions when you think of something like this, or you think of something like the delta loop. So we try to focus really just on these primary actions. Now, the pectoralis major is innervated by the lateral and the medial pectoral nerve. Lateral and medial pectoral nerve. Right now it just sounds like a term. We'll see more where these nerves originate from when we talk about the brachial plexus. Okay? But for right now, it's the lateral and the medial pectoral nerve. When you look at this step here, we've taken the pec major, in this case it's been removed. So you can see here's the origin, over here's the insertion. So all of the pec major basically has been removed. So you're starting to see a little bit of that medial pectoral nerve, what we just talked about. Here's the medial pectoral nerve. You can see a little nub of the lateral there. See the name here. So that tells you that that was innervating, that was passing through this area, innervating the pec major. But this slide is also trying to show you something that's here. It's this cloudy film called the clavipectoral fascia. And you see this term here. Clavipectoral fascia. There's fascia all throughout the body. There's superficial fascia, which is this yellow, lobulated looking fat. And then there's also a deep fascia, which is the whitish, a little more cloudy color, usually directly against the muscles. Okay? So I don't know, you guys, you probably didn't see a lot of that deep fascia when you looked at the body last week. Most of it's been removed, so you can see the striation of the muscle fiber. But just remember, the superficial is the yellow lobulated, the deep is this whitish, cloudy layer, a little bit thicker. So this clavipectoral fascia really helps to form a roof over some of these axillary contents. I think you can see behind here, you've got a blue vein, there's an artery that travels through here, there's a lot of nerves as well, the brachial plexus is back there. So this clavipectoral fascia helps to sort of give shape to these deeper structures, sort of to that region, but also provides a little bit of protection to it. But that being said, there has to be a couple openings in this clavipectoral fascia to allow these nerves and to allow these vessels to pass through. Makes sense, right? So you see a pretty big opening up top, and that's where that lateral pectoral nerve is passing through. You don't see the actual little openings for the medial pectoral nerve. That's all right. There's a couple little openings here that allows that nerve to pass to the technique. That is the clavipectoral fascia. The body has different fascial planes that sort of, for lack of better terms, clump together or thicken. There's a lot in the neck. If you guys have ever studied head and neck before, there's a lot of different branch that comes off of the axillary, which from this view you kind of lose track of it, but it's coming directly out towards you. So if you can imagine this coming straight out of the screen towards you, it's called the thoracoacromial trunk. Thoracoacromial trunk. Then it tells you thorax and also acromion. So it's telling you the sort of the region that this is going to be feeding. And the reason it's called thoracoacromial trunk and not thoracoacromial artery is because it's acting just like a tree trunk. The tree trunk comes out of the ground, and then it splits into different branches, right? So in this case, the thoracoacromial trunk is an artery that comes out of the axillary and then splits into 4 different branches. Those branches are pectoral. Yes, sorry, you're behind the column there. Sorry.
Can you point that out?
I've got the pointer right on top of it,
Okay.
right there. That, like I say, from this view, the thoracoacromial trunk can be about 1 inch long, but from an anterior posterior view, it's just coming out towards you, so it's hard to tell that depth perception. Yes.
The axillary is not identifiable.
Axillary is all of this. Yep, it's all that big guy there, and all of these branches are branches off of the axillary at this point. Thoracoacromial trunk has 4 different branches. The first one is the pectoral. The second one is the clavicular. The third is the deltoid. And the fourth by name is the acromion. Pectoral, clavicular, deltoid, and acromion. So we mentioned those to be complete, but we also mentioned those to show you, again, why the thoracoacromial is called what it is. Because these are the regions that it's supplying. Okay, so it's giving you some blood supply to the pecs, the major and the minor. It's also giving you some blood supply to the subclavius muscle, the muscle that's hidden just underneath the clavicle. Okay? It's also stretching out towards the deltoid, helping to supply the deltoid muscle. The acromion, okay, it actually gives a little bit of nutrient branches to the bone itself. So it's sort of a big deal when you talk about this clavipectoral region. And the next one that we look at is just below the pec minor, just inferior to the ear, called the lateral thoracic. Now, lateral thoracic, if you want to, underneath, don't mark thoracic out, but sort of underneath in parentheses, maybe also put mammary, lateral mammary. That name implies that this is a big blood supply to the breast tissue. Okay, remember how we said the axillary tail comes across towards the armpit? So this vessel that you see here will supply some of the lateral, rounded portion of breast tissue, but also a good portion of the axillary tail that heads back to the armpit. So that's why it's called lateral mammary a lot of times. Now there's one here that you don't see, you got to take my word for it until we get a little bit later. This is called the internal thoracic or internal mammary. Okay? Internal thoracic or internal mammary. It is not a branch off of the axillary. It is a branch off of the subclavian, which is back here. And it comes down this path here. Just lateral on either side of the nucleus, body, all the way down to the side of the nucleus. And it also helps to supply some of the breast tissue, but it also helps to supply some of these muscles, the intercostals here through the ribs. So that's the internal thoracic. It's a branch off of the subclavian, travels down towards the abdomen, just on either side of this one. So far, so good. So I just talked about the intercostals, so we'll talk a little bit more about them now. It's cut out a wedge here on the lateral side of the thorax. Well, what this is showing you is that you have 2 different layers of muscle in between these ribs. And of course, they're called intercostals because they're sandwiched in between the ribs. But if you look at the external intercostals, these are the ones you see here. The external intercostals, the muscles run, fibers run, as if you're sticking your hands into your pockets, sort of down and in. Right? External intercostals, like you're sticking your hands in your pockets, fibers run down and in. They are the most external from this view, which means the muscle that's a little bit deeper to that is going to be the internal intercostal. And notice how these fibers are running up and in, up towards, as if you're trying to reach up towards the maneuver. Okay? External intercostals are usually situated a little bit more lateral on the rib cage. Then would it make more sense to have one big muscle to do those actions instead of two smaller ones running in different directions? So what's the point? Why do we have that?
Is it to help stabilize?
To help stabilize? You're getting there. You're getting there. Think about it this way. And we'll mention this again once we talk about the abdominal muscles. If you have damage to the external intercostal, right? Let's say you're playing pickup basketball, and let's say somebody gives you a nice little elbow, and if you're LeBron, you flop all the way across the floor. Did you guys see that, by the way, this weekend? Oh, man. Draymond's making fun of him. All right, I digress. That was a tangent. That's not my reason. But let's say you damage a little bit of the external intercostal. Okay, let's say you pull the external intercostal away from the rib that's just below, right? So at that point, that means you would not be able to pull that rib upward because you have no muscular articulation. Okay? But the fact that you have two different muscles coming in at two different angles gives you another backup plane. All right, you guys are going to start to see a common theme here with this backup plane. Okay, the body loves backup planes in case we do something wrong. Okay? So you have two different directions of muscle, two different layers of muscle. So that way if you have damage to the external or the innervation to it, the internal can still pick up the slack and vice versa. Does that make sense? Now it'll make a little bit more sense to you for a different reason when we talk about the belly, because there's different sets of injuries that happen with the belly, like hernias. You don't really have hernias in the thoracic region, but you absolutely do with the belly, kind of towards the pelvis. So it'll carry a little different meaning as we go down into the belly. Sorry, I keep seeing these construction work before we're walking around. I see things moving every now and then. Now, underneath, remember earlier we mentioned the costal groove. On the inferior inner surface, there's the groove that allows different structures to run alongside of it. In this case, now you're introduced to those structures. You have an intercostal nerve, artery, and vein. Now, this is the old van. We call this the van relationship. If you start from superior to inferior, van, V-A-N, vein, artery, nerve. Okay? Intercostal, vein, artery, nerve, from superior to inferior. Now, this actually originates on the posterior side. It's showing you here more on the lateral side. But it actually starts to limp out as it works its way up towards the sternum. So it's much more prominent on the posterior wall. So if I was going to look at it upstairs on the body, or if I was going to tag it on the exam, I would try to tag those structures as posterior as possible where they're the biggest. Because that relationship usually starts off pretty standard. It's possible for the vein and the artery to rotate a little bit as they work their way around laterally to the front. I mean, that happens. But usually that fan relationship is pretty standard on the back side. Now just briefly, once we take away the breastplate, and now we're standing as if we're inside the body looking outward, so we're trying to look through the front of the body. There's one more muscle called the transversus thoracis. Transversus thoracis. Another weak muscle of respiration. This one's located, of course, on the inside of the sternum, inside of the rib cage. You can see its attachment points right at the junction of the costal cartilage and the rib, all the way to the sternum. What it's not showing is that internal thoracic artery. The internal thoracic artery from this view is sandwiched in between the costal cartilages and this transversus thoracis. So when you guys go upstairs and you look at the inside of the breastplate, you should be able to see, at least on one side, you should be able to see the transversus thoracis muscle holding that internal thoracic or internal mammary vessel up against the breastplate. Okay? Don't want to belabor that. Now, when you think about normal respiration, we've talked about bony articulations so far, right? We've talked about bony articulations for the thoracic vertebrae posteriorly. We've talked about costal articulations on the anterior side of the sternum. So when you think of normal breathing in and breathing out, inspiration, expiration, you have action that takes place anteriorly, you have action that takes place laterally in the thorax, but you don't have action that takes place posteriorly. And if you just look at the bony structure, that should make sense as to why that is. When you have the ribs that articulate, specifically the head, when you have the head of the rib that articulates with those fat already established that that back there is for stability, not so much range of motion, okay? So that means everything else at that point is going to be a little bit more movable, more free. So you have no bony articulations on the lateral side. You just have the ribs obliquely as they span around the chest. But you have the ribs that circle around from the side, and then they bury themselves on the sternum. Right? You already saw the articulating spots on the lateral side of the sternum. So what this diagram is showing you, this is talking about the anterior side of the thorax, okay? Specifically with the sternum. So when they call this pump handle action, okay? So some of these actions or some of these examples, they start to lose their impact over time because nobody really. Did anybody grow up having to pump water out of a well? Did you really? Where are you from?
Robinson County.
Where at?
Robinson County.
Okay. I'm from Stokes County. Don't be.
My grandma has one.
She still has one?
Yeah.
Okay. Don't be ashamed. Be happy where you're from. It's all good. I'm from Stokes County. You guys familiar with Stokes County? It's like southern West Virginia. You know, it's like first cousin of Fairview. I digress. But it's actually kind of true. I think you can marry your second cousin legally in Stokes County. So anyway, moving on. But the pump handle, a lot of people with well water, they will have a pump that's associated with it. So to get the water to raise up, either you drop the bucket down into the well and hoist it back up, or you have a pump that allows to get the filtration going. It allows you to pump water out of the well. If you guys ever go to Old Salem, they still have a big pump right there in sort of the main quad area that's still functional actually. But what this is trying to show you, and I'm exaggerating when I do this, but it's trying to show you the action of the anterior side of the chest. So not only does it extend outward, but also like at the tip of the xiphoid process, pushes it out in space. Okay, so again, I'm exaggerating, sort of the degree of it, but it pulls it anteriorly and actually a little bit upward. Okay, so that's that pump handle action. That's what it's trying to explain to you there, is the pump handle action. I mentioned the pump handle action because you're going to hear that again once you get into the med class. So then, at least that'll make a little bit more sense to you. Maybe you'll think back to Old Salem, Robertson County, or Calgary, or cousin. Maybe something. I didn't hear my cousin, by the way. You guys have quiet when I said that because you're like, is this serious? No. Now on the lateral side, remember we said there's no bone-on-bone articulation on the lateral side. It's just the oblique ribs that circles around, right? So in this case, this is called the bucket handle action. It's basically saying if you had a bucket sitting here with a handle on it, when you lift the handle up from the side, the handle actually sort of abducts away from the bucket before you can pick it up. So what it's trying to explain is that the lateral side of the rib cage expands laterally every time you take a breath. Okay, every time during respiration, you have lateral movement of the rib cage on either side. So you have anterior, you have two lateral, but you have no posterior movement during respiration, inspiration or expiration. Okay? I can tell bucket handle and pump handle went over very well. Now briefly, we just talked about the diaphragm here. The diaphragm accounts for 85 to 90% of the air that we breathe in. So if you like to live, this is a good thing to have. Okay? The diaphragm started off as two muscles that over time fused together to become one muscle. So that's why you have two different innervations to this muscle. Okay, it's nicknamed, its name is the same nerve, it's just you have it on either side. Okay? So here you'll see the central tendon. This is part of it here, you can see a little bit on the other side, but you see all the donor muscle fiber, and then you see that central tendon. So that's just sort of a remnant of where this muscle is fused together. Okay? So diaphragm is innervated by a nerve called a phrenic nerve. We'll see it again in just a little bit. But when we look at the abdominopelvic cavity, everything that's underneath here, compared to the thorax, and we'll talk about the subdivision once we get down to the belly. At least this will give you an idea of just how far upward the diaphragm actually extends. Because if you'll look, 1, 2, 3, 4th intercostal space, you have the upper dome of the diaphragm on the right side. 4th intercostal space. So if you feel that on yourself, that's pretty high up. Most people don't think about it actually being that far upward. Okay? So that means that the lungs are up here. That means the heart called cruce. You guys, you ever heard of that term before, cruce? Not Tom Cruise. Cruce. Cruce means leg. Okay? Cruce is a generic term that means leg. So when you go through the body, you'll see there's more than one cruce. Okay, so cruce is not necessarily a specific structure. It's just sort of a nickname for a structure. In this case, you have a right and a left cruce for the diaphragm. But it's nothing more than the diaphragm muscle extending downward with the tendon attaching to the vertebral bodies on either side. So that's the right-left cruce of the diaphragm. There's a little opening here. It's called the aortic hiatus. Bonus points if you can figure out which vessel passes through there.
The A.
No bonus points. I didn't say that. Yes, you're right. The aorta passes back through. Now this is a neat way of looking at the body because this is another way of sort of getting your orientation down. So I know we study gross anatomy from an anatomical position standpoint, right? We talked about that last week. But sectional anatomy is another way of looking at it. Now we used to make our own cross sections. We used to embalm a cadaver, freeze it, cut it on a bandsaw about 1 centimeter apart, sand it down, put it in nice plexiglass plate, fill it full of embalming fluid, and then about a year later when it starts to leak, we have to go do it all by hand. Or now you can simply look at a CT, MR. There's all kinds of different programs on the computer and the internet that will allow you to strip away skin and the fascia and sort of take things layer by layer by layer. But CT and MR is definitely used every day, multiple times a day. And it's a very cheap alternative to a lot of these other procedures, so it's definitely used on a pretty high frequency basis. So you need to get kind of used to looking at images that look similar to this as well. So first thing, let's take a look here. Sternum, spinal cords, that tells you anterior, posterior. Just off the lateral side of the sternum on either side. That's that internal thoracic. I know we couldn't see it before, but at least this gives you an idea of where it's at. See those here? Hey, we haven't talked about it much yet, but we will. You got some blood supplies coming from it. But let's look downstream just for a second. There's the old spinal cord. Okay? There's spinal cord. Here's the spinal nerve. So that means this structure is ventral root. Back here's dorsal root. They merge at the spinal nerve. Again, what's the purpose of that spinal nerve? That's right. That's exactly right. Mixing the motor and the sensory information. So at that point, this will split after the spinal nerve into a dorsal primary ramus and a ventral primary ramus. Dorsal, as you can see, heads directly to the back, innervate these erector spinae, transversus spinalis muscles, the true back muscles. Whereas the ventral here follows that costal groove all the way around to the anterior side. Okay, so hopefully that kind of brings things back to the last week, maybe makes a little sense as far as how the ventral primary rami actually makes it to the anterior side of the body. They follow that costal groove. Whereas the dorsal, they just head directly posterior because their path is much shorter distance. But now to kind of bring you back to what we're talking more about today, you see the big picture set up for the thoracic cavity. You have the right, you have the left thoracic area. You also have the mediastinum, which is more related for the heart. Okay, that's a big picture set up. We can talk about it in a little bit more detail in just a minute. Now this is a sagittal view through the body. I don't know if it's true midline or not, it doesn't really matter, but it's close to it. But what this is doing is, this is subdividing the thoracic cage into two different areas. The mediastinum superior and the inferior. Now, what this means is that you've got one portion of lung that would be out here in space, and you've got another portion, the right side of the lung would be over behind the wall. Okay, so we're just talking about the mediastinum. So if we get back to that previous slide, we're just talking about the area that's directly deep to the sternum. Now, again, mediastinum means middle compartment. Okay? Mediastinum means middle compartment. But the mediastinum isn't truly in the midline, okay? Because the heart sits in the mediastinum. And the fact that the apex of the heart sits in the fifth intercostal space but 9 centimeters left of the midline. That tells you that it's not all happening right behind the sternum, right? Apex is fifth intercostal space, 9 centimeters left of the midline. So that tells you that the mediastinum isn't truly the middle compartment. It's just the middle compartment of the 3 compartments, the right thoracic, the left thoracic, and the mediastinum sort of sandwiched in between those two. Okay? That being said, you can subdivide the mediastinum into a superior and an inferior. So let's go back to our sternal angle. Here's maneuvering your body. That's the sternal angle. Remember we said that if we drew an imaginary plane directly posterior, that's the lower border of the T4 vertebrae. So already that sternal angle subdivides the superior mediastinum from the inferior. Now superior mediastinum is just that. There's no other subdivision. The inferior mediastinum is subdivision. Anterior, middle, posterior. Right now it just sounds like terms. We'll talk about the different structures that sort of sit in each of these. But that's actually exaggerated for the anterior. The anterior is actually it's not very deep at all. It's actually pretty thin. Okay? The middle is the largest portion of the inferior mediastinum. And posterior, of course, is the most posterior, but it's also the longest as far as the distance that it travels. You'll see that it travels all the way down to about the T12 and L1 vertebrae. I think we talked a little bit more about the mediastinum. Just, flip over to the next. So see now here we can start to plug in some of the organs, some of the structures that are sitting in these spaces. Again, it's showing you the sternal angle, the T4 vertebrae, so that is trying to show you the sternal angle. All of this up here is the superior mediastinum. You can see things like the trachea. You'll see some of the aorta as it passes through here. But look at the inferior mediastinum for a second. This is what I mean by the anterior being pretty narrow. It's not very deep at all. This is it. This area here is the anterior mediastinum. And basically what's in there is fat. You guys know what the thymus gland is? Heard of the thymus before? The purpose of the thymus is to sort of boost an infant's immunity until its immune system can catch up to help the baby sort of take care of itself. Okay, so this is a very big gland, very early in life that becomes irrelevant. So instead of just completely disappearing, it just turns to fat. So at this point in all our lives, the anterior mediastinum has layers of fat in it, and that's remnants of the thymus gland. That's really about all that's in the anterior. Now the middle, when you think of the middle mediastinum, you're thinking mainly of the heart. The pericardial sac that surrounds it and the heart. There is a little bit of fat that surrounds the pericardial sac on everybody. Some people have a little bit more than others. But there is a little layer of fat that surrounds the pericardial sac on everybody. So that's basically the middle mediastinum. And then when you think of the posterior mediastinum, remember we said this is the one that goes to T12 down to L1 or so. That's where you see the aorta traveling downstream. You see the inferior vena cava coming back upwards from blood into the heart. So there's other structures that we'll talk about to do a little bit more of the inferior mediastinum. Now to focus solely on the superior mediastinum for a second, this is an anterior posterior view, so you can see a little bit more than what we saw in the previous one. We talked about the trachea just briefly. Here you see the trachea, you see the cartilage rings. So you can follow this downward. And then this dotted line is supposed to represent the sternal angle. So again, this is that T4 level. Notice how the trachea splits right at the T4 level. It bifurcates, it splits. This is another one of those landmarks for the sternal angle, the bifurcation of the trachea. So if you'll notice here where the trachea splits, this specific structure, this specific splitting of the trachea is called a carina. You guys may have heard of that before, the carina, C-A-R-I-N-A. That is the bifurcation of the trachea, and that happens right at the T4 level. What structure from this view is directly deep to the trachea? The esophagus, that's right. The esophagus sits directly behind the trachea. So when we talk about tracheal when we talk about tracheal rings, it's not exactly a ring. Okay? It's not exactly like it's a circular ring. It's more like it's a moon shape with the esophagus sort of butting in behind it. So if we were looking at this from a superior to inferior view, this is more what we're looking at. This is the trachea from anterior, posterior. Here's the esophagus. Okay? So it's got probably 66% of it is a cartilage ring on the anterior side, but not so much on the posterior. It's more flexible for the esophagus to sit in behind here. There's a little bit of room in between the esophagus and the trachea, and it makes sense because the esophagus should be closed, right, unless we're eating. So when something's passing through, the esophagus will swell. So this allows for room for the esophagus to swell anteriorly, posteriorly, laterally as well. Okay? But now as you work your way down towards the sternal angle at T4, the esophagus and the trachea early on are right behind each other, right in front of each other. But as you work your way down to T4, the esophagus starts to slip away a little bit because it's going to head towards the left side of the body where the stomach's at. So usually right at the T4 level, you're starting to see a little bit of the esophagus as it creeps out. You don't see it here, it's not really showing you the esophagus, but to be complete, this is what you would see in that superior medius sinus. So you've got esophagus, then you have trachea, splitting into T4 level, sternal angle. The next structure that you would see as we work our way from posterior to anterior, here you see the aortic arch, as well as the three main branches that come off of the aortic arch. Now, do we have any college football fans in here? 1.5. Be confident, yes. All right, you guys remember the old system before there was a playoff? What was it called? BCS. Yes, the BCS, the bowl championships here. I always remember the BCS because this is the initials for the structures that come off the arch of the aorta. BCS, brachiocephalic, left common carotid, left subclavian. It's also alphabetical for you guys that hate college football. BCS, brachiocephalic, left common carotid, left subclavian. Now, brachiocephalic, the name tells you what? Brachium is arm, cephalic is head, right? So this is the branch that is heading up towards the arm and the head on the right side. But it's not called the right brachiocephalic. It's just called brachiocephalic because there's not a left brachiocephalic, right? Or correct, I should say. The left common carotid and left subclavian are direct branches off of the arch of the aorta. So that's why you have a brachiocephalic, sort of an extra step in the process on the right side that you don't have on the left. Brachiocephalic, left common carotid, left subclavian. But when you look at the veins, you have to work backwards on the veins. You have to work retrograde because this is draining back into the heart. So here you would see a right brachiocephalic vein, a left brachiocephalic vein, merging together to form the superior vena cava. So there's two brachiocephalic veins and only one artery. Okay, but you're seeing all of this in the superior vena sinus. Confused or review? Somewhere in the middle. Cool. You see just a hint. Yes.
I'm sorry.
Go for it.
Okay, you said you had one brachiocephalic artery.
That's a true story.
Okay, and then a left common carotid and left subclavian.
Yes.
But then when the veins, you said the
There's a left brachiocephalic vein. There's a right brachiocephalic vein. Both of those merge together, forming superior vena cava. And the fact, I didn't go too far down the rabbit hole with this, but the term brachiocephalic again is arm and head. So this is taking the venous drainage from the head to the arm on both sides, merging that together. That's how they get the drainage. But like we said, for the artery, there's only one brachiocephalic artery because on the left side, the head and the arm blood supply come directly off of the arch. On the right, they don't. They come off into the trunk, but then it's into it. Any other questions there? So the superior mediastinum, you see a little hint of the pulmonary trunk. You see just the upper margin of the pulmonary trunk. Now, the pulmonary circuit is what you would see that takes blood to the lungs. Okay, you're talking about to the lungs, returning from the lungs, etc. Okay, that's the pulmonary circuit. So you're seeing the pulmonary trunk, but more specifically, you're seeing this whitish-looking structure here. And this is actually connecting the pulmonary trunk to the arch of the aorta. Okay, this is called the ligamentum arteriosum. Ligamentum arteriosum. So if your wheels are turning a little bit, it's the ligament artery. Okay, that doesn't quite make sense. But this is a remnant from fetal circulation. During fetal circulation, this ligamentum arteriosum had an opening in the middle of it. So the name was a little different. It was called the ductus arteriosus. Ductus arteriosus. In that case, it's more like the artery duct. So it's sort of implying that this was an open channel. So not to get too far down the line, but you don't need really the pulmonary circuit in utero because that's what the central blood does. It supplies the oxygen. So any blood that was going to go to the lungs is now shunted back to the other side of the heart to send that oxygenated blood to the rest of the body. Okay, so what this is a shunt. It's taking the blood that would have gone to the lungs that has already been oxygenated and passing it back into the systemic system, which is here through the aorta. So the ductus arteriosus was the open channel. Now that it's closed off, because after birth you do your breathing on your own, you supply the oxygen to your own blood. So this closes off and hardens. So that's how it gets the term ligamentum arteriosum. So it's us when it's open, and it's when it's closed. Ductus arteriosus becomes ligamentum arteriosum. But all that's happening up in the superior mediastinum. Now again, this sort of goes back to what we mentioned a little bit earlier, how the mediastinum needs middle compartment, yet you see how it's sort of pushed off to the left side. We mentioned that the fifth intercostal space, 9 centimeters left of the midline, is actually the apex of the heart. So that implies that the mediastinum does push over more on the left side than it does on the right. It's giving you this walled off area, but if you look, you see this lining that surrounds the long on the right. You see this lining that surrounds the long on the left. Yet there's a small little window here and here that remains open. Those windows are for the pulmonary vessels. Remember we just said the pulmonary vessels are what's supplying or what's taking blood to the lungs to become oxygenated and bringing it back to the heart. Okay, so these are the little windows that allow those vessels to communicate back and forth between the heart and the lung on either side. Otherwise, these areas are basically walled off from each other. So what it's showing you here is that you see the blow-up area here. This is called the pleura. It's showing you the pleura, that god-awful Carolina blue color lining that's traveling through here. That's the pleura. This is the lining for this region. Now, if I said the term visceral, what does visceral mean?
Related to organ.
Organ. Okay. So parietal, in this case, means wall. So visceral is organ, parietal means wall. So this layer that is on the inside of the rib cage, that touches the ribs, that's the wall, right? So that would be the parietal layer of the pleura. And the portion that's touching the lung, in this case, you see it here, the portion that's touching the lung is the visceral because it's on the organ. So this parietal and visceral layer is basically like a balloon that's surrounding this entire area on both sides. It has a small little window in it that allows the heart, again, like we said, to communicate back and forth with the lungs. Parietal, visceral, pleura. Now, as we go through the rest of the body, that parietal and visceral will mean the exact same thing. We talked about the back on everybody. The nerve is sort of embedded within that fat. So when you first look at the heart on the lateral side, either side of it, you may not quite see it because it's just embedded just deep to that pericardial fat. Okay? That's the phrenic nerve. And the last thing that we look at here that we're introduced to in this region is the vagus nerve. I'm sure you guys have heard of the vagus nerve before, right? If you study cranial nerves at all, the vagus nerve is a cranial nerve. This is located a little bit further. It's also located in the inferior mediastinum, but where we're seeing it right now, we're sort of being introduced to it in the superior part of it up top. So again, here's the arch of the aorta. You see the bifurcation of the trachea at T4, and there's the esophagus making an appearance now. See that in behind the trachea. We're looking for the left vagus. You see it here, and the right vagus. You see it here. And these nerves, again, we said are cranial nerves. Where we see these nerves are actually pretty wide. I mean, they can be whatever distance that is. These nerves can be very wide compared to a lot of the other nerves. Because, listen to the name vagus. What does vagus mean? What does vagabond mean? What does wanderer mean? It means Vegas. No, it's the wandering nerve. A vagabond is a wanderer, right? So there's no Metallica fans in here, I get that. But a vagabond is a wanderer, okay? It's something that just wanders along. Sometimes you might think it's aimlessly, sometimes it might be on purpose. But it's like a nomad, a person that has no real home. They just travel around all the time, right? So the vagus is nicknamed that because it is a cranial nerve that works its way all the way down to the distal part of the colon. Okay, so it's doing things head and neck, it's doing things thorax, it's doing things abdomen, it's doing things pelvis. Okay, so it's the wanderer, it's the vagabond nerve. It's got a lot of things to do. So at first, this nerve is very large, it's very prominent, because it's going to give off some of its structure in the form of nerves up top, but it still needs to be able to pass downstream to do everything that it needs to do down low as well. Okay, so up top, it's still very wide. But you're introduced to it in the superior mediastinum, right vagus, left vagus. Now the left vagus, as it wraps around the arch of the aorta, it gives off one specific structure. You'll see it here. I'm trying to circle it. You only see just a little hint of it. Okay, and it's called the left recurrent laryngeal. Left recurrent laryngeal. Recurrent means it's circling around. Laryngeal tells you its destination is going to the larynx, the voice box. Okay, so the left recurrent laryngeal. It runs underneath the arch of the aorta, and it should be just posterior to the ligamentum arteriosus. So I think you can see that on the screen. Okay? Underneath the arch of the aorta, just behind the ligamentum arteriosus, that is the left recurrent laryngeal. There is a right recurrent laryngeal. We don't see it from this view at this point. That nerve comes off a little bit further downstream, but you are introduced to the left. Now the vagus, you can kind of see from there that the vagus continues along the esophagus. It will pass downstream to the belly. I don't want to talk any more about it unless we pick it up once we do the belly. But it's just sort of showing you that wandering aspect to it as it heads downstream. And the last thing I mentioned is that the vagus, we talked about being a cranial nerve, it's a cranial nerve 10. But when you talk about autonomics, have you guys talked about autonomics before? Fight or flight, sympathetic, parasympathetic, that stuff. You're really being introduced to a parasympathetic nerve here. Okay, so this is cranial nerves 3, 7, 9, and 10 have parasympathetics to them. So you're looking at the parasympathetic innervation from the vagus at this point. And we'll talk more about autonomics when we see the sympathetic change, which of course by name tells you the sympathetics. Once we look at a little bit deeper into the thorax. Okay, but for right now, you're being introduced to the parasympathetic part of this region. That's the vagus nerve. That's a good spot to leave off. Unless you guys want to go somewhere. We still got plenty. It's okay to say that. That's all I got. You guys have any questions? Did you have any questions from